We are off. All right, Giulia, here we go. So 5, 4, 3, 2, and 1. All right, folks, welcome back to the podcast. Very excited to have as my guest today, Dr. Giulia Suro. Giulia, welcome.
Thank you for having me.
So, Dr. Suro is a psychologist, author, and researcher in Washington, D.C., specializing in the treatment of eating disorders and trauma. In addition to her outpatient clinical practice, she is also the director of research and at Monte Nido, a leading eating disorder treatment conglomerate. Her 2019 workbook, Learning to Thrive, is highly regarded in the field. She regularly contributes to the Journal of Eating Disorders and European Eating Disorder Review, as well as publications like Psyche and ThriveGlobal on the intersection of eating disorders and trauma. Um, Welcome to the podcast.
Thank you. Thank you for having me. I'm excited to be here.
Awesome. So before we get going, share with the listeners where you're from originally and where you are currently.
That's a one answer for both. I moved around in between, but I'm from the DC area originally, left for school and jobs, and then came back right before the pandemic.
Okay. All right. So really interesting field you're in, specialization you're in. I'm going to start with a broad question here, but how the heck did all this start for you?
Yeah, it's a great question. I was initially very geared towards having a career in the VA. I studied trauma in graduate school. I did some clinical rotations in the VA. Was wanted to be a VA clinician. Sort of saw myself working for the government
Why?
professionally.
Why? Why the VA?
Why the VA?
Yeah.
Okay, so we're okay, a little bit of a longer story. I initially, my first interest that sort of got me into psychology was severe mental illness. I have some personal familial connections to severe mental illness, like schizophrenia or bipolar disorder. And so I did some work in that area, and I found the settings to be um, disheartening. I found the clinicians to be a bit apathetic. And I really wanted to work in an area where I felt like I could accomplish something, that there was more hope. And I really fell in love with trauma. This was in the early 2000s, like CPT, cognitive processing therapy, was sort of gaining traction. I was trained in prolonged exposure, and it's like you do these protocols and see improvement. And so it just felt very hopeful for me. And I really loved my trauma cases that I had early on.
So the experience, you mentioned familial experience, with severe mental illness and trauma. What inspired you? You felt you could make a difference. I had a similar experience myself. Was was it always becoming a psychologist or a therapist or what?
It's so interesting, but I feel very lucky in that I knew what I wanted to do pretty early on. I've been, I think, a bit of an empath. As I'm sure maybe you can relate, many of your listeners, right? Sort of like into feelings, interested in therapy and psychological approaches. I knew, honestly, before I graduated high school that I wanted to do clinical work. So I was sort of a straight shot through undergrad, getting experience, and then applying to graduate programs.
So you get into graduate programs, you're passionate about learning about trauma, you're geared towards the VA.
Mhm.
What unfolds?
Yes. So what unfolds is very coincidental. I needed to sort of diversify my CV. I was getting ready to apply for internships and I wanted to sort of broaden my experiences. There happened to be a very small, at the time, very small residential program for women with eating disorders, like 2 miles from my graduate school. Um, and so I thought I had no training in eating disorders, no, not a single class in grad school. Maybe it had been mentioned in sort of a diagnostic class, but no experience at all. And so I did sort of a 2 day rotation there, and really not only just really fell in love with that population, but I found that the clients were honestly just as traumatized as the individuals, the veterans I worked with at the VA in terms of their symptom presentation, their trauma exposure, obviously very different than combat, but it treating an eating disorder in those higher levels of care is trauma treatment. It just wasn't named that. And so I got to sort of get a lot of really rich clinical experience with these very complex diagnoses, doing really intensive trauma work.
What was it about the uh, the clients there in the eating disorder clinic that struck you?
Yeah, have found that certainly like trauma comes with shame, right? That's known. And I knew for certain that the veterans I worked with were overcoming a lot of shame just to ask for help and get the
Mm,
help that they very much deserved. I found that my clients with eating disorders experience such a gaslighting experience, sort of what their symptoms meant. And even within the mental health field, like I still feel like we have a long way to go in terms of talking about what an eating disorder is, what drives it. Many of them had had such a failure experience time and time again of not sort of getting over their issues. Why can't you just stop this dieting? Like just very toxic messaging, even from their primary care providers and therapists. Meanwhile, like the trauma's just raging. It's not even been touched. Many of them didn't even identify with like having PTSD. It wasn't something they felt that they could own.
mhm.
And so it really like the need really spoke to me, like being able to just attack these individuals, attack in a positive way, attack in therapeutically. These individuals just really extensive need that just was not getting met at the time. And really, it hasn't been until recently that the intersection of eating disorders and trauma has become more well known, but I still don't think it's trickled into the
Which
mainstream.
is so crazy. I mean, it's
It's
just so
crazy.
crazy to realize that that is the reality that we're living in right now. Okay, so you have this incredible experience. What happens after that? What do you do?
I stayed. I couldn't leave. I stayed. I really fell in love with it. I stayed. I came back as a postdoc. I was a therapist for several years. I became a clinical director, and then now I'm in sort of this interesting position of gathering research on individuals who are experiencing eating disorders from like the full spectrum of inpatient, really really severe, through outpatient, and trying to understand what is driving these behaviors. And for many of them, I think much more than any of us even realize, it is trauma.
Um, we talking 90%, 95%, 99%? Is it safe to say?
I, yeah, it's high. I mean, in higher levels of care, it's the majority or close to the majority, right? And we know people
Yeah.
underreport. We know the more severe an eating disorder is, you're more likely to have a co occurring diagnosis of PTSD. The earlier your eating disorders start, so like when we see individuals that start engaging in eating disorder behaviors at younger and younger ages, like early adolescence, late childhood, like it's more likely to have PTSD. Um, Marginalized communities, so BIPOC, LGBTQIA, they experience eating disorders at the same rates, but they are more likely to have PTSD, right? So it's pervasive.
Let's take a sidestep here. How would you define an eating disorder? What is it?
It's a really good question. It's a term that is broad and it speaks to a very diverse range of behaviors that speak to a fractured relationship with food and body, right? On the surface, that's what it looks like, right? And I sometimes describe eating disorders as an iceberg, right? Like we have the things above the surface that catch people's attention, that catch your parents' attentions, providers, things like binging, purging, laxatives, abuse, food rituals, all that stuff. Like underneath, there are these massive systems that are driving them: nervous system dysregulation, attachment wounds, dissociation, right? Perfectionism, control, right? And often what is pressing those levers is an origin of trauma.
Mhm. So, um, let's talk. I want to jump here and talk a little bit about your book, Learning to Thrive. What was the impetus for that?
Um, I had found a lot of difficulty understanding what does the evidence show is an effective treatment for eating disorders, right? So CBT at the time, and I think still remains the gold standard, but like efficacy rates are, I think it's sort of like tossing a coin, right? It's very difficult to study these illnesses. So I was looking for approaches in therapy that were transdiagnostic, meaning they could be applied to any human who's struggling with challenges, right? And so for one person with an eating disorder, that's very like restrictive, controlled rituals, thinking numbers, keeping food logs, very tight, emotionally restrained, right? And for someone else, it's like more chaotic, impulsive, binging, purging, self harm, right? And they both are diagnosed with an eating disorder and they could be treated in the same place. So I
Hmm.
was looking for approaches that could be applied to anyone, right? And I found acceptance and commitment therapy as a really beautiful holistic approach that I thought was effective, not only for eating disorder behaviors, but symptoms of PTSD and trauma response. So Learning to Thrive is the first workbook for lay people that anyone could pick up from Barnes and Noble or Amazon and apply it to themselves in a self-help format.
Is there a particular demographic that targets eating disorders, would you say?
What do you mean?
Well, is it just across all the spectrum of individuals, white, black, BIPOC, whatever, it doesn't matter. It claims no specific target in a sense.
Yes, yes, that's exactly right. We see consistent rates of eating disorders across race and ethnicity, LGBTQIA. Men, although very understudied, account for potentially one third of all eating disorder
Wow,
diagnoses.
surprising.
But yeah, yes, but of course, like there is such a big gap to fill in terms of who's getting the treatment,
Right.
right? We are not reaching all the people who need it, and I think many of the people who need it may not even know they have an eating disorder because they don't fit what they maybe see as sort of a stereotype or meme of what an eating disorder looks like.
So give us an example of that.
Yeah, I think to be honest, and I interact with a lot of therapists or people in my neighborhood who ask me who I treat, right? And when I say eating disorder, like still see we're sort of collectively stuck in a Lifetime movie conceptualization, like going back to the 90s of a young white woman, college student who starts to diet and it goes too far, right?
Right.
What we know that sort of that restrictive eating disorder that exists in a smaller body, someone who's undernourished or underweight is actually it's much less common than someone who struggles with an eating disorder in a larger body who engages in binging. That is much more common, right? But those individuals are more likely to receive weight counseling, weight stigma, be overlooked by providers, right? There's still actually a long way to go in terms of educating medical providers around eating disorders. So this statistic might be a bit outdated, but at one point in time in the last 10 years, the average psychiatric resident received less than 2 hours of training on eating disorders. So we still have to there's a lot of education that we need to sort of get out there.
Yeah, that stereotype that you gave was exactly the one I had in my mind. I think
Sure, sure.
a lot of us do.
Right.
So, Julie, give us an idea here. And I know every case is different, but
Yeah.
how do you, and you mentioned ACT, do you work in groups at all?
Not currently, but I did
Okay.
as when I worked in treatment centers. Yes.
Okay. How do you, and you mentioned trauma, of course, as the kind of underlying foundational issue in many of these instances. How do you begin to work with a client? And I know that's a broad question, but
Yes.
where do you,
Yes.
what do you
Yeah.
do? I'm really
Great.
curious.
Yes. Great question. Well, the first thing I'll say that if anyone like hears 10 seconds of this, the first thing I feel strongly about sharing is like a thorough assessment. So any client I see for the first time, I'm doing a thorough trauma history, asking directly about sexual trauma. And anyone who has a trauma history, I'm asking about your relationship with your body. Do you ever try, what does your relationship with food look like? Have you ever binged and purged? And really probing for those behaviors. as I said, many in the mental health field don't receive any training on eating disorders. So like making sure you get the full lay of the land, right? Because what acceptance and commitment therapy, the beautiful thing about it is sort of like the behaviors in and of themselves don't matter. The thoughts, the content of them doesn't matter. We're understanding the function, right? So when you binge, is it a manifestation of wanting to feel numb or wanting to feel, is it the sort of the manifestation of restricting, being in control and then losing control, right? Like those are two
Hmm.
different drivers of behavior, and ACT really gets under the surface. So let's understand what these behaviors are doing for you and then find more flexible, balanced ways to meet them. And we're doing sort of similar things with thinking. So, are your thoughts about food, um, I need to push my body to the brink, or the less I eat, the more in control I am, or if I'm in a larger body, I'll be more safe from predators, right? Like, what are your thoughts about food? And then what is the function of them? Are they keeping you safe? Are they making you feel protected? Are they making you feel in control, right? And how can we change your relationships with those thoughts so that you're holding them more lightly? You're not so attached to them, taking them to be truths. And how can we find other ways for you to meet your needs?
When you first started, I'm curious about what your stance was, some of the maybe errors, clinical errors you made, what those look like,
Yes.
what you learned from those.
Yeah, yes. Yeah, there's certainly many, right? I first of all, like stepping into this world with a lot of personal biases about what an eating disorder looks like and what a person in an eating disorder, what their body might look like or what behaviors look like lots of that early on. But what I think most about, and sometimes I honestly like have real regrets about these clinical experiences. The way I was trained, and many in the eating disorder field, we were trained was if there's trauma, don't touch it until their eating disorder is under control. Get the eating disorder under control first and then deal with the trauma. Because if you start doing trauma work and their eating disorder is still raging, the eating disorder will flare up. It'll be too hard to manage both. So just like don't do trauma work.
Mm.
That has now been really debunked. Some of our own research has shown that sequential treatment, so doing eating
Mm-hmm.
disorder first and trauma work, actually leads to increased relapse, right? And it makes sense intuitively. Like if you take care of someone's eating disorder in treatment and then you sort of send them on their merry way back to their world where there's triggers and
Right.
stress, right? Like they're going to feel activated and use their old coping skills. And it just results in individuals going through the treatment cycle again and again and feeling like a failure and becoming very discouraged, right? What we know now is if you can sort of provide some safety and containment in an intensive therapeutic setting, right? Do the trauma work, even if there is still active eating disorder symptoms. Do the trauma work, right? Like run, don't walk. And if you do that, there can be this ripple effect where the eating disorder symptoms also go down as the trauma symptoms are responding to treatment.
That's really interesting. How long ago, are we talking decades when that was kind of the state of the art in terms of treatment?
Not that long ago, and I think
Not
I
that long
still,
ago.
yeah, I still interact. I sometimes give talks and presentations about this to eating disorder professionals who they are hearing this for the first time, right? Or they're sort of challenging their stance currently.
When I'm listening to you talk, I'm reminded of something Gabor Mate says, kind of what she's famous for in a sense is like where you see addiction, you inevitably see trauma. The people coming to you, are they, a lot of them, some of them, none of them, aware that there's trauma? I mean, a lot of people don't even know what do you mean traumatized? I haven't been traumatized. This is the way I was born, right? I mean, with domestic violence, et cetera, et cetera, et cetera. This is how I grew up. It's not trauma to me. But I'm just curious if you found a lot of people are like, well, I never thought about that. This. So,
Yeah, it's you're spot on, right? Like we only know the water we're swimming in, and many of my clients, if not most of them, have experienced like a discrete traumatic episode, and the majority of the time it's a sexual assault, right? Sexual trauma, early childhood sexual trauma, right? But many of them grew up in early childhood environments that were dysfunctional, that were toxic, that were abusive, that were invalidating, right? And then they emerge from them feeling detached, not having a relationship with their bodies, feeling out of control. That all gets played out with the food, right? And that's what they're sort of like, bad girl, get the food under the control. You have to leave college for treatment, right? Like that's what they're sort of punished for. That's what people are responding to. And meanwhile, like this whole context that brought them to this point gets a bit overlooked. So sometimes I do feel like I'm sort of presenting a new view for the first time for a lot of these
Hmm.
clients.
So people listening to this, therapists of all kinds, consumers as well, is there, how would you ask if when you're doing that assessment, how would you ask about an eating disorder?
So my first question, just to sort of like ease in a little bit, is tell me a bit about your relationship with your body, right? Like how would you describe it in a couple adjectives? Are you guys friends, enemies? What has it been like over the course of time? And then like tell me a bit about your relationship with food. And if I were to watch you eat in a day, just sort of observe you eating, what are some things I might notice?
That's
Right. And I
interesting.
think another
Yeah.
another misconception about eating disorders, like there are so many individuals, highly functioning, ambitious, fully formed adults out in the world, adults, right? Like parents, grandparents who are binging and purging, who are counting calories, who are skipping meals, right? And we don't think to ask because they're coming to treatment for anxiety or depression or other things. And these sort of feel, many of these behaviors are normalized, right? You look on
Hmm.
Instagram and you see fasting, you see a
Hmm.
lot of this stuff that's sort of adjunctive or adjacent to it, and it feels normalized, right? And so we want to get a sense of like what does the way you eat look like. And I asked directly about have you ever purged or binge?
If you look at it as a continuum, when is counting calories something to be concerned about? I mean, one could easily say, well, if you're binging or purging, that just seems to automatically be in the red zone of concern. But counting calories, I mean, I think a lot of people do count calories.
Mhm.
When does it become concerning? Should it be?
Yes. Yes. Good question. So I will sometimes ask, what percentage of your headspace does this take up? Right? Like how much time, if we were to create a pie chart of your mind, like how much time is spent focusing on food? And does it get in the
Mm-hmm.
way, right? Like, are you not at a birthday dinner? Are you not eating cake? Or are you not at
Mm-hmm.
an Italian restaurant? Are you like not letting yourself get pasta? Are you holding yourself back? Are you limiting yourself? Or if you do indulge, are you compensating in a way that's not helpful to you? Um, those are some of the questions I might ask.
Yeah. All right. So, can we talk about this other project you're working on, or is that we don't want to talk about that? We're not going to talk about that. All right. So, learning to thrive, who's it for? Who would you say
It's
who?
for anyone. Yeah,
Okay.
it's for anyone. It is a self-help book, so it's meant to be for someone who does not currently have the time or resources to find a therapist who specializes in acceptance and commitment therapy, which does require some training, right? It's a bit of a specialized approach. This is something you can take and you're getting sort of your own ACT therapist at home.
And as we kind of close out here, in the beginning, you said you were like born to be a therapist in a sense, but what is it, Julia, that allows you to do this work you're doing? I mean, obviously you have a passion for this field and specialization. What is it about you that allows you to do it, that makes you good at it, or probably great at it?
Oh, I appreciate that. I That's a really good question. I think I think it's very tough to be a girl in the world right now. And eating disorders affect people of all genders, right? But I do have, I think, a personal identification with the challenges that can come with just being female in today's world, and all of the messages that are sort of thrown at you about what your body should look like, how you should express yourself, how you should express your sexuality, right? And the toll it can take. To be honest, think on some level, being an adolescent, young female, a young woman in today's world is like in and of itself a little t traumatizing,
Yeah, I
right?
would
And so,
I would agree. I mean, I have a 9-year-old girl. What do you say to a 9-year-old girl who says, you know, Dad, am I skinny?
yeah,
How do you respond to that?
yeah, great question. So I have a 3-year-old girl. So it's become more personal to me too, right? So my go-to, right? Like all of the stuff that's thrown at girls today and all of the stuff that an eating disorder puts on you disconnects you from yourself. You're not hearing yourself, you're not feeling yourself, you're not feeling your emotions, you're not feeling anger, you're feeling disconnect, you're not feeling hunger, right? And so directing the attention inwards. And so what I say to my daughter is like, I could get emotional saying it, but you are Hazel. Know that. You always need to
Mhm.
know Hazel. Go back to Hazel. How does Hazel feel? What does Hazel think? Right? Like staying connected with yourself, right?
As opposed to what? The external cultural social environment?
Yes,
Okay.
exactly. Right?
In other words, what is
Yes.
Hazel feeling? How do,
Right. Yeah, what does
okay.
Hazel feel, right? And, like, when Hazel, is full at dinner and doesn't wanna eat something, like, I'm like, "That's awesome that you feel full in your tummy. Great job that you feel that. Keep feeling what your tummy tells you," right? Like, or
Hmm.
when Hazel feels angry, like, don't lose that it gets lost. So much
Hmm.
noise, so much CRAP, I don't know if I can curse here, right? Like,
You can,
just gets
you
crap
can.
so much crap gets layered on, and it
Yeah.
gets harder to know what's real for you, and
Yeah.
we start our attention becomes so external facing towards getting reinforcement, towards getting likes on social media, towards being sexually appealing, right? And we want to bring attention back to the self and those internal cues, right? And that is what eating disorder recovery is in large part. It's feeling your feelings, hearing those feelings, responding to them in a way that helps you. And also, there's that parallel process between emotions and your hunger fullness cues. So, just as we want you to
Hmm.
feel anger, feel sad, we want you to feel hungry, feel satiated, feel full. Those are equally important.
I mean, I'm just thinking about how just intense that is and how oftentimes we don't want to feel. People don't want to feel. I don't want to feel what I'm feeling because of
Right.
A, B, and C. And then just to work with people to allow them or allow them to feel that is so powerful. It's so inspiring. You know, you can feel it.
That's real. Yeah. I agree. I agree. And that's really like more than anything, I think the greatest toll of an eating disorder is it disconnects someone from themselves. It is a numb state. I mean, I think another misconception is people who don't eat, they must be hungry all the time. Like the metabolic system, it shuts down. It is numb. It is a numb state. There's no hunger, there's no full, it's just blank, uncomfortable, anything is overwhelming, right? There's just like a real loss in communication with internal cues.
Yeah. Fascinating. All right, Julia. Really appreciate you coming here. I mean, this is so complex and it's hard for me to approach this in this time allotted, but what's the best way for people to reach out and contact you?
Yeah, you can reach me. I have a website that will connect you to my email. It's juliasuro.com, and my name is spelled the Italian way, Giulia, S as in Sam, URO. I'm also newly on Instagram at Julia Suro, PhD.
Okay. We'll look that up here at the show notes page at the traumatherapistpodcast.com. Love to have you back. And again, thank you so much. It was a pleasure.
Thank
All
you.
right. Take care.
Bye.